I'll pass it along to Beth and Dr. Ahmed to get us started. Thank you so much for your time today.
Excellent. Thank you, Deirdre, for the welcome. I am thrilled to be here. I am so honored to have this opportunity to talk about one of my passions, which is women's health, and talk about some of the challenges that women are faced with daily. And so through my almost, hard to believe, 18 years of practice and education, my eyes have been opened, and I've learned a ton in terms of the quality of care that is provided, the inequalities, and there are quite a few uncomfortable truths about the scope of biases within our healthcare system. And before we get started, I definitely want to make it clear that a 30-minute presentation will not uncover all of these truths, and that this is really, truly just a tip of the iceberg. But again, thank you for having me. And so as we move forward, I want you to take a moment and think about what social justice means to you. Okay. And when you think about social justice, it may evoke some emotions. It may evoke, you may remember some personal experiences. And some of you may just be embarking on your journey and may not be able to answer it and are wanting to learn more about social justice. And when we talk about social justice, it really revolves around the concept of equality and human rights. It looks at the opportunities, the privileges, wealth of people around the world. It really looks at how these rights are manifested. And it also looks at redressing the inequalities based on gender, based on race, religion, age, and other characteristics. And so we are narrowing the scope in this presentation a little bit. We are looking at social justice in healthcare, and particularly social justice in women's health. And so when we refer to social justice in healthcare, it really translates into the delivery of high quality care to all individuals. And so achieving social justice is critical in healthcare. It is critical to ensure that all individuals can maintain their highest level of health and wellness. It's a basic right, and our basic right to health has a huge impact upon many other rights that we have. So our right to food, right to housing, right to work, right to education, right to non-discrimination, the right to access to information. And we know that when healthcare is accessible, when it's affordable, when its importance is really truly understood, that families can prosper. And good health provision is really a gateway to improved outcomes. And so many of you in healthcare or with social justice probably have seen this quote before, but it still resonates and rings true, that of all forms of inequality, injustice in health is the most shocking and inhuman. And that was from the late Dr. Martin Luther King. And so as we move through this presentation, we will be focusing on women's health specifically. I'm going to take a more specific look at maternal health care and inequalities around access to care, not only here in the United States, but also locally, right here in our backyard, right here in Indiana. And so just a couple definitions as we move through the presentation. And so when we look at women's health as a whole, we're looking at diseases and conditions that women experience across their lifespan, okay? Maternal health narrows it a little bit. And so this covers the health of women during preconception, so prior to pregnancy, during pregnancy, and our postpartum periods. And for those of us that are mothers, we know that there's a series of important events, series of changes, physical changes, emotional changes, and social changes that occur prior to pregnancy, during pregnancy, and well after those 40 weeks of gestation and into that first year of childbirth, after childbirth. We know that these changes are natural, but they can be extremely stressful, and they have health consequences for women across a woman's life. And so before we move forward, I think it is important to kind of look at a little bit of history. Where have we been, and then where are we going? Okay. And I just picked a handful of achievements in women's health, and I'm not going to go over all of these, but just some highlights of our history and achievements in women's health. And I have to always include our pioneer, Margaret Sanger. In 1914, she coined the term birth control. And in 1916, she actually opened the first birth control clinic, and she was promptly arrested 10 days later. In 1960, so close to 50 years later, the pill finally arrived, and the Food and Drug Administration approved the use of the birth control pill as an oral contraceptive. 1969, a health columnist did an expose on birth control and really looked closely at the side effects they were seeing in the use of birth control, including stroke, heart disease, depression. And it cost her job, but it led to a federal hearing on the safety of birth control. The NIH, in terms of women in clinical research, in 1986, they adopted a policy where they were required to include women in clinical research. About 3 years later, further investigation found that women were not being included in the research, and that only about 13.5% of the monies were going towards women's health research. And they still were not being included. And so in 1993, there was a Revitalization Act. And that Revitalization Act finally established a mandate to include not only women, but minorities into clinical research. And this is imperative when we look at researching medications. How it impacts men is very different than how it impacts women. So including them in that research is imperative. 1998, the New Mothers Breastfeeding Act was introduced. And this actually protected breastfeeding under civil rights acts. So it provided provisions for breastfeeding mothers to express milk in the workplace, provisions for unpaid time. So very important for our working mothers. And then in 2010, the Affordable Care Act. And Affordable Care Act has increased the number significantly of American women who have access to health insurance. It has lowered the cost for many women, and it's improved preventative services. And so it required providers to provide evidence-based preventative services to women at no cost. And so this included mammograms, this included well women visits, this included birth control, breastfeeding support. It also included the women could no longer be denied health insurance coverage because of a pre-existing condition. And those conditions included breast cancer, pregnancy, and depression. And so as we look at some of these achievements in the women's health movement, which was really in the 60s and 70s, and they looked at changing childbirth practices and really with a goal to improve healthcare for all women. They did look at many different problems and confronted different problems, including discrimination that impacted women's healthcare. So there were some really positive changes. But when we look at where we are today, we're still leaving women behind, okay? We know that systemic forms of discrimination, structural racism, implicit bias occur in our healthcare system. And more specifically, we're going to talk about in women's health. And this has a detrimental impact on the health and well-being of tens of millions of American women. And as we look at some of the social justice issues, so access to equitable quality care, reproductive rights, implicit bias, I am going to start with implicit bias and talk a little bit about how that the trickle-down effect does impact maternal morbidity and mortality, or reproductive rights, access to quality care. But implicit bias, it's derived from individuals' learned stereotypes and prejudices. and it automatically influences one's behavior. And when we look at implicit bias in the healthcare setting, research has shown that it impacts patient-clinician interactions, it impacts treatment decisions, it impacts adherence to treatment, and most importantly, it impacts patient outcomes negatively. And I'm going to share an example here from a study that was done by the American Heart Association. And the example is about heart disease. And so heart disease is the leading cause of death among women. But in 2012, a study that was conducted by the American Heart Association, they found out that 44% of women were unaware of this. They did not realize that heart disease was the leading cause of death among women. And the highest percentages that were unaware were Black women and Latina women. And so the American Heart Association wanted to know why. Why was there this discrepancy? And they explored that question, and they found that many women reported that their physicians seldom, if ever, talked to them about heart health. They, in some cases, actually misdiagnosed obvious symptoms of heart disease as panic, stress, or even hypochondria. And so this is a blatant example of how biases really do put women's lives at risk. And furthermore, when we look at racial and ethnic disparities in women's health, we look at an increased rate of preterm births, cervical and endometrial cancer, cancer deaths, and maternal morbidity and mortality. And we're going to touch on that a little bit more here shortly of our current state of maternal morbidity and mortality. More American women are dying of pregnancy-related complications than any of our developed countries. And it only in the United States has the rate of women who die, has it been rising. And nothing really sums up this situation that we face in America currently than this fact here. And this just, it resonates with me deep. It blows me away that in 2020, the US remains among the most dangerous developed nations for a woman to give birth. And so that is significant. And we're going to talk a little bit more about the statistics around that here momentarily, but we must solve it. It has to do with implicit bias. It has to do with clinical bias. It has to do with the impact of social and economic factors. And we need to fully address all these disparities to better serve our vulnerable populations. And so we are going to talk a little bit about morbidity and mortality here, and I wanted to give you a little context into these statistics by just providing some birth statistics in general from in the United States from 2018. And so there was close to 3.8 million births in 2018. Prenatal care was initiated in the first trimester with about 77.5% of these pregnancies. About 10%, and we'll talk a little bit about why prenatal care is very important, but 10% of these babies were born preterm, meaning that they were born prior to 37 weeks gestation. A third of these deliveries were C-section, and Medicaid was a source of payment for 42.3% of these deliveries. And so as we move into some other statistics in terms of maternal morbidity, those statistics will come into play. So severe maternal morbidity includes unexpected outcomes of labor and delivery, and it results in significant short and long-term consequences. And so severe maternal morbidity, it's impacted more than 50,000 women in the United States. And these rates have doubled, nearly doubled in the last decade. And so when we look at pregnancy-related death in the United States, 70 women experience a near miss. So, and to put that into a little bit more context, Every 12 hours, a woman dies due to complications resulting from pregnancy. And additionally, 2 babies die each day as a result. And these numbers are disproportionately higher for moms and babies of color. And so we're going to take a closer look at who is at risk. And so it's our younger moms. So our moms that are under 20 years old. It's our older moms, age 40 and older. It's those who receive Medicaid as a source of payment. And we saw on a previous slide that 42% of the births in 2018 received Medicaid as a source of funding. Residents in low income, okay? When we look at comparing the incidence of severe maternal morbidity in white women compared to African-American women, Hispanic women, it's significantly higher in our Black women. So they looked at a study from 2012 to 2015. When compared with white men and women, 166% higher risk of severe maternal morbidity in Black women, 122% higher for Hispanic women, 117% higher in Asian Pacific Islander women, and 148% higher for American Indian and Alaskan Native women. That's a significant difference. When we talk about severe maternal mortality, the CDC uses the term pregnancy-related death as the death of a woman while pregnant or within 1 year of the end of pregnancy. You'll also see another term by the World Health Organization that looks at it within the first 42 days after birth. We're going to focus on within the first year after birth with the CDC's definition. And it's regardless of outcome, duration, or site of the pregnancy. It can be from any cause related to or aggravated by the pregnancy, but it does not include any accidental or incidental causes, okay? And so when we look at the United States as a whole, maternal mortality has increased by 16.7%, all while those around the globe, maternal mortality rates have decreased during the same time period. Each year in the United States, about 700 women die as a result of pregnancy or delivery complications. And experts estimate that nearly 60% of these maternal deaths are preventable, 60%. And so who is at risk? And again, we're looking at our women of color who are at higher risk of maternal mortality. And so 37.1 deaths per 100,000 live births for Black women, 14.7 for white women, and 11.8 for Hispanic or Latina women. And the variability and the risk of death by race and ethnicity, research has shown that there's several factors. And we've already covered a couple of them, but implicit biases, structural racism that result in inequitable access to care, inequitable access to quality care, prevalence of chronic diseases as well. And so when we look at some of the factors in terms of that impact maternal morbidity and mortality, there's behavioral risk factors, okay? So smoking, obesity, opioid use. We know there's an opioid crisis here in the United States. Access to care. Preconception health is the health of women prior to becoming pregnant. And from 2008 to 2012, 43% of women delivering in a hospital had some risk factors for severe maternal morbidity and mortality. And that included whether it was a pre-existing condition, pregnancy-associated disease, could have been advanced maternal age, but that's quite a bit that are at higher risk and carry those risk factors. When we look at access to care for prenatal care, if there's late onset to care, fewer visits or both, it significantly increases the risk of insufficient gestational weight gain, increases the risk of ongoing prenatal smoking, increases the risk for premature rupture of membranes, It increases the risk of mom not breastfeeding postpartum. And it increases the risk of poorer outcomes when one does not seek prenatal care or receive adequate prenatal care. And so we understand that there's a numerous amount of health, societal, economic factors that contribute to this crisis. But one I'm going to really focus on is the unequal access to healthcare. And the term I'm going to use and that you will hear about is maternal care deserts. And maternal care deserts are counties in which access to maternity health care, the services are limited or absent. And so this could be either through lack of services or barriers to women's ability to access that care. So maybe they do not have transportation to get to an OB appointment. Maybe they do not have health insurance. So whatever it may be, they have some type of barrier to access care. And so it's estimated that 7 million women of childbearing age live where there is no or limited access to maternity care. And when we talk about maternity care, so that's preconceptual care, that's care throughout the pregnancy, your prenatal care, postpartum care, it is critical. It is a critical component of maternal health and positive birth outcomes, especially in light of the high rates of mortality and morbidity that we see here in the United States. And Marcia Dimes put together a really impressive report, and it's called Nowhere to Go, Maternity Care Deserts Across the United States. And this is a look at all the counties in the United States, and it looks at maternity care deserts, which there's no access to maternity care, low access to maternity care, and moderate access to maternity care. And so when we look at this, about 2.2 women of childbearing age live in maternity care deserts. That's close to 1,100 counties that are considered maternity care deserts. So what that means, again, they have no hospital offering obstetric care, no birth center, no obstetric provider. And in 2017, almost 150,000 babies were born to women living in maternity care deserts. And when I first started really researching maternity care deserts, my first thought was, it's probably a majority in rural areas. And I was surprised to find that that is actually not the case. Among these women, so we're looking at these maternity care deserts, 1 in 3 live in a large metro area or urban setting. So it's not just our mothers who live in rural America. When talking about rural America, there are only about 8% of obstetric providers that report practicing in rural areas. These maternity care deserts typically have a higher poverty rate, lower median household income than those counties that actually have access to maternity care. These women are giving birth, and it's putting them at risk of serious complications when they don't have access to maternity care. And when we look at those women who do not have access to routine quality care, these moms and babies have a significant increased chance of maternal and infant mortality and morbidity. And so I wanted to take a closer look and kind of share what we see here in the United States as well, or in Indiana as well. And in Indiana, 27% of our Hoosier counties are considered maternal care deserts, okay? And so our maternal mortality rate here in the United States is significant. And in Indiana specifically, it's 41.4 of 100,000 live births for white women, and a shocking 53.4 of 100,000 live births for African-American women. Our maternal mortality rate here in the United States is on par, or with Indiana, is on par with countries like Egypt, Mongolia, and Cuba. And Indiana's rate is twice as high as our neighboring states, Kentucky, Ohio, Illinois, and Michigan. And so I'm going to share another story of a young woman, Indiana resident, and her journey to access healthcare postpartum. So this is a young woman. She is 23 years old, and she is an Indianapolis native, actually lives outside the Indianapolis area. And she gave birth to a handsome young boy, and she was breastfeeding her 1-week-old son. And this was a couple years ago, when she began to feel a really significant pain in her chest. And she recalls the pain being excruciating. She said it was much worse than the 10 hours of labor that she spent a week before. It began to spread up her neck, her head, and soon she began to slip in and out of consciousness. She quotes, "It was weird of how fast it was happening, and I was like, this is not right. I had no idea it would be related to pregnancy." She lives about 45 minutes to an hour from a maternal care provider. And by the time she made it there, her blood pressure was 186 over 126, and she was in a hypertensive crisis. She eventually was diagnosed with postpartum eclampsia, which is a rare pregnancy disorder complication. It can cause seizures, it can cause stroke, it can cause organ damage. She went on to spend over a week in the hospital away from her new baby. And she quotes, "It was just a relief I got to the doctor when I did." And I bring this up because there's so many women across, not only in Indiana, but across the country, that don't make it to the doctor when they should, because they do not have access to maternal care, postpartum care, prenatal care at their disposal. And so she was lucky. She was able to receive the care that she needed and recovered fully and is doing well. But it's just a reminder of the challenges that women face and the importance of access to quality, equitable maternal care. And so as I look at our current state, I have hope. I have hope that one day no woman will be left behind, and that access to quality care, quality health care, regardless of income, regardless of race, regardless of a woman's geography, that they will have that access to that equitable quality care. And I wanted to share some things that are being done now to move us forward and to help with this. And one is telemedicine. And I think telemedicine has come to the forefront through our pandemic, and we have really found the value in it. And we also, there's value in it for our obstetrical patients, for our women's health patients as well. They can reach those individuals that live in maternal care deserts. They can reach those individuals that have barriers to access the care. Also, funding for family planning services. And so family planning services really allows women to decide on their family size. It gives them access to contraceptive services, pregnancy testing, counseling, and these funding and access to these services have played a critical role in the United States. And in 2014, it helped women avoid about 2 million unintended pregnancies, thereby preventing nearly 1 million unintended births. Okay. And then also policy, creating more equitable health outcomes by establishing state maternal mortality review boards. And so this has been a push across the United States, right here in Indiana as well. They established this review board here in Indiana in 2017. And they looked at all of the pregnancies and births of 2018. And they just put out a report in December of 2020, looking at all of these pregnancies, births, morbidity, mortality. and provided recommendations to reduce these health disparities that we are seeing. And finally, standardizing clinician education around implicit bias. And so that implicit bias in trauma-informed care to really decrease stigmatizing messages. My hope, and I feel like a lot of academic institutions are moving towards this, of providing that training in academia, as well in our healthcare facilities, and ongoing education throughout our providers' practice. It's imperative. As you can see, the implicit biases really do trickle down and impact care across our healthcare system. So when it comes to fighting disease and maintaining health, it's clear that sex, gender, and race do matter, and equitable health outcomes and the health of our society do depend on it. And so I'm going to hand it over to my colleague, Dr. Ahmed, to talk a little bit more about social justice and breastfeeding.
You can share. You will. Okay, I'm going to start to talk about social justice in breastfeeding. My research focus, actually, I am a lactation consultant, and my research focus is in promoting breastfeeding among vulnerable population and mothers of preterm infant. So, next slide. So I will first summarize why breastfeeding and what is the importance of breastfeeding before we start. And I know that we have different audience level. There is a lot of benefits actually for breastfeeding, for mother, for baby, for community. So just a quick benefit for the mothers actually, that breastfeeding immediately after giving birth decrease postpartum bleeding as a result of the oxytocin hormones, and also utilizing all the fat that's accumulated during pregnancy to actually return back and faster to pre-pregnancy weight. Studies also found that prolonged breastfeeding with good time of breastfeeding, we'll talk about the duration later, provide protection against breast cancer and ovarian cancer. And also prolonged breastfeeding protect the mother on the long term of metabolic diseases like diabetes and cardiovascular diseases. And with exclusive breastfeeding, a lot of mothers, they experience lactational amenorrhea, and that actually decrease also the blood loss and maintain or decrease or improve the iron deficiency anemias they have during pregnancy or after giving birth. Next slide. So there is also a lot of benefit for infant, which is the most common protection is against upper respiratory tract infection. And we see a lot of lower infections of otitis media among breastfeeding infant. Also gastroenteritis is very, very low in breastfeeding infant, with also the infection of the late onset sepsis in preterm infants. And the longer-term effect with also the type protection against type 2 diabetes. And there is a significant a lot of studies supported that the lower rate of sudden unexpected infant death syndrome among breastfeeding infants. And several studies also found the association of decreasing lymphoma, leukemia, and different types of cancer. And we all see the difference between, obesity and overweight, comparing breastfeeding infant with formula feeding infants. Next slide. with the psychological benefits for mother and the child, the improving the bonding between the mother and the relationship between the mother and the baby. In terms of maternal mood, in case of successful breastfeeding, that we see a lot of lower rate of postpartum depression, but at the same time, we see a lot of high anxiety if there is any breastfeeding problems. So that's why we actually have helped the mother to decrease breastfeeding difficulties. We see a lot of neurodevelopmental outcome for infant, and also decrease in the neuroendocrine responses to stressors. Next. So in terms of economic benefits, of course, we see lower visit to clinics, providers, like lower level of utilization of healthcare settings, and also decrease in the cost in terms of the formula cost. And Bartik actually and her colleagues, they estimated about like if 90% of US women exclusively breastfeed, they could save actually at least 13 billion per year. So all these benefits are dose effect, like, which means like the more or the longer the breastfeeding, the more the benefit. So how long the mother should breastfeed? This is according to the American Academy of Pediatrics. Exclusive breastfeeding for 6 months. And when we say exclusive breastfeeding without any supplementation, without any herb formulas, even water, we don't need any water in the or anything during the first 6 months. And then the mother continue breastfeeding with introducing complementary food until 1 year or as long as the mother baby needs, or based on their decisions. The World Health Organization, they also recommend 6 months of exclusive breastfeeding, and then continue breastfeeding until 2 years or as long as mother baby wants. So we'll talk more about disparities. Next slide. So we see a lot of disparities in breastfeeding, and this is according to the statistics from the CDC recent statistics. And you can see non-Hispanic Black infants, they actually have lower rate of initiating or any breastfeeding compared to other ethnicities like Asians and non-Hispanic whites and Hispanic infants. Younger mothers, and they actually have lower rate of breastfeeding. And I put this here because there is also another report from the CDC highlighting that African American or Black mothers are younger compared to actually other ethnicities. So, and we had a study at Eskenazi for pregnant women. We recruited the mother during pregnancy, and we were watching their sleep and to see the effect on like breastfeeding or delayed lactation after that. And we have 65% African American, and the average age was 23 years. So they are very young, and they have like difficulties with breastfeeding. Next slide, Beth. So this actually linear graph explain, or show the breastfeeding. Yes, we are improving. Breastfeeding rate is improving among the different ethnicities. Non-Hispanic white, non-Hispanic Black, Hispanic, and Asian Pacific Islanders. And you can see non-Hispanic Black mothers, they have really low rate of breastfeeding. And this is at 6 months. This is the linear graph at six months. The bar graph actually explains the difference between non-Hispanic white and non-Hispanic Black. And this is according to the CDC breastfeeding indicators from the CDC. So breastfeeding rate at birth, those are the indicators that they use it to evaluate breastfeeding. At birth, which is the initiation, you can see the difference. And any breastfeeding at 6 months, and the rate also of exclusive breastfeeding at 3 months and 6 months. And as you can see, non-Hispanic Black, they really actually they struggle with breastfeeding, and they have a lower rate compared to other ethnicities. Next slide. So I'm going to talk about causes of disparities, and I would like to use the social ecological framework. Actually, this is one studies about, it was by Johnson, summarized, factors that really affect African American, but we also will discuss other ethnicities. So socioeconomic, social ecological model actually focus on the individual. What are the interpersonal, factors, the community, policy, and the socio-historical context. And I will take one by one. Next slide. So when we talk about individual causes, those minorities mothers have very high rate of morbidities. As Beth mentioned, they have all types of morbidities. Like, for example, African American, they have the highest rate of prematurity. So all of these morbidities really affect breastfeeding. So by different ways, like some metabolic diseases, or some like diabetes, gestational diabetes, preeclampsia, they are associated with delayed lactation. And delayed lactation, the milk doesn't come in until like maybe after 72 hours after birth, after giving birth. And also the associated, breastfeeding difficulties. So in these terms, they need a lot of help and a lot of support from this. We see also a lot of lack of knowledge about breastfeeding. Like up till now, I can't actually believe that like some mothers, they don't know what is the benefit. And we actually saw this in some situations. Like I remember I was volunteering in the WEC office, and we put, all the benefit of breastfeeding, and we had a mom came up and she read all the, the benefit, and she said, I want to breastfeed my baby. So the knowledge about the benefit is very important, and we need to give the mom the information and help her to take an informed decision. We see also a lot of lack of self-confidence, lack of self-efficacy, and I cannot do it. So this is actually a very important factor in continuing breastfeeding. Hispanic mothers, they face a lot of challenges in terms of financial strains, like job stability. They also have a very cultural beliefs about breastfeeding, like breast milk is not enough. So we see a lot of high rate of like supplementation. We like exclusivity rate is low among Hispanics mothers. Next. In terms of interpersonal causes, the environment around the mothers actually help her to actually either to stop breastfeeding or continue breastfeeding. So lack of support from the family, lack of support from the husband, the father, the partners, especially the support from mothers and the grandmothers. So when we say when the mother feels that, oh, I don't have enough milk, so I feel that I don't have enough, oh, give one formula. So this is the one formula that's actually the first way to actually decreasing the breastfeeding rate. Also, the good model or the role model in the family or around her actually peer support. Normalization in some communities, actually breastfeeding is not the norm. So the normalization of breastfeeding. In terms of community, we see a lot of lack of access to lactation consultant and lactation support. Like Beth talked about the desert, like this desert actually apply also to lactation support. We, especially in rural areas, in some urban areas, they don't have access to lactation consultant. And this is not far, like around in counties around us, they don't have actually access to a lactation consultants. Insufficient breastfeeding education from provider, like especially gynecologists or obstetricians. So during pregnancies, they need to know about, the importance and the benefits of breastfeeding. So we need to actually have a prenatal breastfeeding education. The unsupportive work environment, like especially among low-income mothers, the actual low-income African-American mothers, they actually go back to work very early, and they have unsupportive work environment and unflexible work schedule. And this is by law now. They have to have their own place to pump their breast milk. They have to have their own way of supporting breastfeeding. And of course, we talked about if the environment or the neighborhood is not supportive, will not help the breastfeeding. Next slide. So we also, in terms of policy, like we can see a difference, and we can see a lot of like unequal implementation of maternal paid maternal leave. So some companies, they really stick with the 12 weeks, but some they don't do this. And especially like if they are working, certain companies actually, they ask parents or they ask mothers to go back very early for, and they don't give the paid maternal leave. And in some communities, especially with the high neighborhood with the Black populations, they don't have access to baby-friendly facilities. Baby-friendly facilities, these facilities, they implement certain steps that help the mothers actually to start breastfeeding immediately with the skin to skin and no formula supplementation, unless it is medically indicated in this term, and helping the mother after discharge actually to breastfeed. In terms of history, actually, we also know, we all know about the delivery and how this affected the trust in healthcare settings and providers, and how this actually affected the mothers, and of course also women during pregnancy after giving birth. Racism, discrimination, bias, we talked about this also, and I will give example about how this racism and discrimination really affect breastfeeding. Next slide. So I want to share with you this article, and this is actually one of my colleague, Karen Robinson. She from Marquette University. She is African American, and she is working in breastfeeding or lactation research. And this is actually her most recent publication, and discussing racism, bias, and discrimination as a modifiable barriers. We can modify, but this study actually highlighted a lot of issues, not just the effect on breastfeeding, but also highlighted the lack of documentation of the impact of racism or discrimination. So can you give the next slide? I have some highlights from her. So this is a highlight from her. It is a scoping review, and but has a lot of good information. So it really, like, the racism really affected the breastfeeding initiation and duration. Also, the biased assumption of the provider. Like they assume that this mother will not breastfeed. This mother will not continue actually to breastfeed the baby. So this is affected actually the quality of the support they actually receive. African American mothers received fewer referral to lactation support, and they had a limited access to lactation help when they have any problem. The most important part in this actually study or article, they actually documented the lack of research studies that really document the impact of racism. And she couldn't actually find, she wanted to do like a systematic review with meta-analysis, but she couldn't find enough studies. She just actually included 5 studies to actually highlight. So we need more research, more studies that really actually document the impact of this discrimination. And she also highlighted that racism, bias, discrimination is part of these causes of disparities. So when you feel comfortable to go to your provider, this is very important. So if you can't feel comfortable or not feeling welcoming to go to your provider, you will not go. So this is actually part of the causes of disparities. Next slide. I know that we took a lot of time. So we cannot deny the efforts that actually having to address disparities. The CDC and also the United States Breastfeeding Committee, they actually have a lot of initiatives and a lot of help and support, like addressing the LGBTQ community. We actually have a webinar to actually how to support this population, reaching our sisters everywhere. So this is actually a nonprofit organization that actually helping, actually training African American lactation consultants and providing services for African American mothers. And also the natural breastfeeding initiatives, they actually provide funding for communities to actually also support minorities mothers. Next slide. So in order to address these disparities, we need to focus on all the barriers across all the layers of a social ecological framework or model, like individual, interpersonal, like all kind of policies that help and support and enforcing policies. Actually, we have laws, we have rules, but actually not implemented equally. And also discrimination, reducing the discrimination with educating actually the healthcare providers, the public health providers, and overlooking the assumptions that actually really affect the quality of care that they provide. I think this is what we have, and we are open to any question.
Great. Thank you both so much for your time preparing and sharing all of this important information. It really affects so many people, and it's just really hopeful and eye-opening to see some of those statistics and talk about some of those issues. We do have a full 15 minutes for open question and answer from our attendees. So anyone who's here who has a question, you're more than welcome to unmute your audio or your video to ask your question out loud. If you're more comfortable, if it's easier for you to type it in the chat box, feel free to do that, and I can share that out loud for you and for the rest of the group to hear the answer. So are there any questions at the moment from our audience?
This is Eric Palmer. I have a question. Probably, I don't know, either person can answer, but it might be more directed at Beth. So I'm just wondering, do you think with the increase in the amount of females that have gone into medicine, because our healthcare industry in the United States is so heavily medically driven. Do you think that the increase of women going into medicine itself, as opposed to maybe going into nursing or pharmacy or something like that, do you think that's going to help with some of these inconsistencies that we see when it comes to healthcare?
That's a great question, Eric. And I definitely think it could absolutely help when we have women representatives in the medical community. But I also think we need to really begin to, because nursing is so female dominated, providing more education around implicit bias training and building that confidence in our nursing students to speak up and step up. So I definitely think it could help, but I think we also have to take it a step further and reach all those across the medical community. Does that make sense?
Yeah, it does. Thanks.
Mm-hmm.
Thanks so much for that question, Eric. We do have a question in the chat that's somewhat related and asks, how can we as administrative medical staff help to combat these disparities? So like those other roles in the medical offices.
I can say something, and if you want to add this. So as administrative medical staff, actually, if you are in administrative position, so making sure that all the policies applies, like making sure all the staff are like really trained to provide high quality care. So this is if the administrator actually have, the opportunity and the chance to actually to make sure that there is actually everybody have access, increasing, the access to care in terms of improving the personnel, the providers, increasing the number of providers, improving access to, more, or hiring more actually in terms of breastfeeding lactation consultant to help. So if you want to add, Beth, anything.
No, I agree. I think ongoing education and support, providing that to at an administrative level, and then obviously letting that trickle down and providing that support and education to all levels in the healthcare setting is imperative. And being committed to that training and ongoing training and education for our healthcare professionals, I think is really important.
Thank you. Oh, go ahead.
You all mentioned that young African-American women were not necessarily interested in embracing breastfeeding. Is there use of social media or technology to help with the promotion of the importance of breastfeeding, as well as the marketing of the educational component of breastfeeding for this population? Do you all know of anything specifically how social media or technology is helping to educate and promote breastfeeding?
So there is actually several apps for, like I have seen several studies actually developing an app for based on, the result from, or an interview based on the African-American mothers' comments. And also the funding, the CDC also and the NACHO, they actually provide a lot of help and support for African-American. But in terms of, the education, I believe that it really needs to start as early as like maybe middle school, high school, and including actually the family members to help actually to instill the importance of breastfeeding among girls, teen girls, and young adults.
Thank you. Thank you for that question as well. We do have two other questions that came in the chat. One was related to the question about administrative staff members and on healthcare offices. It says, along those lines, how would you recommend those of us who do not work in healthcare can help combat those disparities? And then the second question, in case you want to go back and forth, is, do you think that nursing equipment like breast pumps, nursing bras, et cetera, will ever be covered by insurance or provided at a free or reduced cost?
Do you want to go? You want to answer all questions. If you want to answer any question, I can do the breastfeeding.
Sure. Go ahead.
Equipment. So in terms of breastfeeding equipment, if you remember the Affordable Care Act, actually they really had support and providing pump to mothers after giving birth, and in some insurance they really cover, and some insurance they really don't cover actually the pump and all the supplies. So, but I'm not sure right now. I know that some, even with based on the Affordable Care Act, they wanted to take off this actually lactation support and the breastfeeding equipment.
In terms of that, I think there are some Medicaid plans. I know here in Colorado, there are some plans that do include pumps for women, which is nice. It definitely varies in the plan though. In terms of the question, recommend those who do not work in healthcare to combat the disparities. And I think it goes along with answering the previous question, through the administrative medical staff is education. So continuing to educate yourself, get involved. There's some wonderful associations out there, nonprofits that are working tirelessly to combat disparities, particularly in women's health. And I can put a list of those. I should have put a list of those together for you guys, and I could maybe put that in together and share that with Deirdre, if that would be okay. But again, getting involved, speaking up, being educated, and I think is the best way to help combat these disparities.
I want to also add, like, as I mentioned, you don't have to work in the healthcare setting to help decreasing. We talked about the environment around the mothers. If it is supportive, supporting the mother during pregnancy and after giving birth, and helping the mother to actually encouraging them when they struggle with breastfeeding. We see some mothers just need assurance. So it's just, you are doing a great job. So this is actually what you actually could help with. So helping, being the community or the environment that really support the mothers.
I have a question going off of what Dr. Ahmed just said, like being the support or the community that reassures the mother. Are there like support groups for new mothers like locally? I guess I'm just unaware of what I can do as someone who's, an undergrad at Purdue, but want to do everything that I can do to help these mothers give the best life for themselves and their children. Yes,
for a support group, if the mother actually on the WIC, if she is on the WIC actually provide a lot of help and support after giving birth, and they have access to a lactation consultant, at least in our Tippecanoe County. They have a great actually lactation support group and team. They actually provide a lot of support. In some hospitals, they have a support group after giving birth. And I know that in our local hospital, like IU Health, they have a support group after giving birth, and it was face-to-face, but now it is virtual. So like support group is part of the 10 steps that actually with the baby-friendly hospital, if they are baby-friendly, they have to provide postpartum support and support group. And also, there is a lot of Facebook pages for Indie Mom. This is a Facebook from Indianapolis Mom, Indianapolis area, around this area also. They provide a very good support, and some hospitals also they have Facebook support for postpartum and breastfeeding mom and pregnant woman.
I'm just going to tag on to that. There's another great program, and this is nationwide, and I know it's in Indiana as well. And it's called the Family Nurse Partnership. And this is a program that works, and it's nurses that go out and they work with new moms. So it's usually it has to be their first pregnancy. And this nurse will follow them through their first pregnancy and all the way up to 2 years after birth. And so it's to provide education, support. It's a phenomenal resource for these mothers. So if you're interested in more information about that, it's Family Nurse Partnership. And they typically are in multiple counties around Indiana, actually across the United States, but a phenomenal program that supports pregnant mothers and new mothers. So.
Yeah, I'm glad that you brought that up. I was thinking about community health workers, and it sounds exactly very similar to what you're talking about there, just specifically on this. But how do you see this integrating with this growing trend of telehealth and where the opportunities are versus, just how do you see, I'll stop there, just how do you see those kind of community health work programs integrating with telehealth?
I think there's a big opportunity there to reach these women that have barriers and cannot get to get care, but just to provide education. So Dr. Offman talked about a lot of women don't know the benefits of breastfeeding. We could utilize telehealth to provide education around breastfeeding and the benefits, and provide education around risks for morbidity and mortality and prenatal care. I think there's a lot of opportunity there to reach those individuals that may not seek prenatal care, that may not continue with prenatal care due to different barriers or challenges. So yeah, I think there's an opportunity there for sure. Anything to add to that?
Yeah, telehealth it's very important right now, and a lot of community health organizations, they moved from home visit to virtual meeting and home. But I did a study about using digital health in providing breastfeeding support, and a lot of mothers actually they told us that we cannot actually use they cannot actually see accurately or diagnose actually the problem. Like if the baby have tongue tie or something like this, they need actually face-to-face. But it is very, very actually very helpful in providing education and providing psychological support, telling the moms that she is doing a great job, addressing some simple questions related to lactation. That will be good. But mothers actually said it does not replace the face-to-face actually visit, and especially in breastfeeding problems.
We do have another question in the chat that asks, could licensure compacts between states for healthcare providers help with access to care to these underserved communities?
definitely think it could, in terms of being able to move across state lines and provide care. I just looked at this actually recently. I think there's 33 states, and from a nursing perspective, that have a compact licensure, which is significantly more than when I graduated. But I definitely think it opens up that door, especially for those individuals that are very interested in serving the underserved communities, providing rural healthcare, gives them that opportunity and more of an ease of transferring from state to state to provide care. So I think it could open up that door for sure. Anything to add on that? That's a great question.
Yeah, it depends according to, you know, the license and what is the limitation of this license.
Mm-hmm.
Yeah, if you are able to use it across the states. So
right,
this is
right.
very important.
Thank you both for those responses. And thank you to everyone who's been asking questions and just engaging with this conversation. We do have a couple of minutes left. If there's any final question, feel free to ask. And if not, I will let all of you know via email once we have this recording posted on our website so that you can go back and rewatch it or share it with anyone who might be interested. But I'll keep an eye on the chat in case there are further questions. There's lots of thank yous in there, and I'll go ahead and wrap us up. And if there are no more questions, thank you both of you so much for your time today, for your preparation. Thank you to everybody who joined us and engaged in this conversation. Please feel free to check out our website, and we hope to see you at future seminars and encouraging all of our communities that we talked about today as we go forward. I hope you all have a great day and stay safe and warm out there in this wintry weather.
Thank you.
Thank you so much.
Thank you.